I'm very glad to be here, for the last 14 years, I think. And it's very good that there are situations like this in which doctors and patients meet each other and exchange information. We learn from you, you learn a little bit from us, and together we go forward. Complex Chiari is a terminology which has come out in the Chiari literature a couple of years ago. The paper which started this was a paper by Dr. Brockmeyer. The Brockmeyer is a neurosurgeon at the University of Utah, and he is a pediatric neurosurgeon, and he has a focused interest in the field of Chiari-1 malformation and disorder of the craniocervical junction. Everybody knows about this distinction, this classification between Chiari 1, 2, 3, and 4. Everybody has also heard about this classification Chiari within the domain of the Chiari 1 malformation with the Chiari 0, the Chiari 1, the Chiari 1.5, these all being part of the same pathological spectrum. You also heard about this terminology, true Chiari 1 malformation and false Chiari 1 malformation. The true Chiari 1 malformation is a condition in which the pathology is in its most purest form. It is a condition in which the tonsillar herniation has been driven by a small posterior fossa. And the small posterior fossa is either a congenital mutation or an inheritable trait. False Chiari 1 malformation is any other disorder in which there is a tonsillar herniation, okay, but cannot be confused with a Chiari 1 malformation because the cause for the tonsillar herniation is something else. It can be something pushing, pulling, making the tonsils dangle. This is not the focus of this speech. You also heard, especially the people who followed the educational videos on our website for the last 10 years, the distinction between simple Chiari 1 malformation, which is just Chiari 1 malformation by itself, the Chiari plus, which is Chiari plus something else, like for example Syringomyelia or EDS, etc., and the Chiari redux, which is the typical problem of somebody who had the former diagnosis of Chiari, got an operation, still has problems, and they need some additional attention. The new terminology, which stemmed from this article of Dr. Brockmeyer from 2 years ago and has kind of caught fire among the professionals in the field, is the division between simple Chiari 1 malformation and complex Chiari 1 malformation. In the simple Chiari, there is just the Chiari malformation by itself, with all the constellation of signs and symptoms, and also the presence of incidental findings, which means you have the Chiari on the radiology and the radiology report, but you have no symptoms whatsoever. On the other part of the spectrum, there is the complex Chiari. The complex Chiari in concept is very similar to the concept of Chiari plus. Is the Chiari plus something else. So what is this something else? In the articles of Dr. Brockmeyer, he makes a laundry list, which is summarized in these 2 slides, and is the brainstem herniation, which is practically the Chiari 1 malformation 1.5, so not only the tonsils, but also a part of the brainstem comes out of the skull. The medullary kink, which means that the inferior part of the brainstem, instead of having a very gentle curvature, is getting punched in the stomach by some kind of structure which is in the area. Retroflexodonta, we're going to see some pictures, but is a part of the spine which is not what it's supposed to be. A normal clival cervical angle, which means that the head and the neck are not in a harmonic angle. Occipitalalization of the atlas means that the first vertebra, instead of being independent from the skull and independent from the vertebra below, is fused to the skull, and that changes the biomechanic of the skull. It's like imagine you walking with a stiff leg or with a cast in your leg. Your gait is not going to be the same. Basilar invagination, again, one part of your spine is not what it's supposed to be. Syringomyelia, there is no need for me to tell you about, and also scoliosis when it is linked to the Chiari 1 malformation in a cause and effect relationship. Now, so this is pretty much is a Chiari plus, but in the focus of Dr. Brockmeyer in his contributions, the focus is about a narrower part of the Chiari plus domain, which is the true Chiari 1 malformation plus something wrong at the craniocervical junction. So the purest form of complex Chiari nowadays is summarized in this slide, is the Chiari 1 malformation plus something wrong at the craniocervical junction. The craniocervical junction being the borderline between the skull and the upper part of the cervical spine. And this is a classic example. So everybody sees that there is something wrong with this tonsil. This is the back of the second vertebra, the back of the first vertebra, the base of the skull over here, and the tonsil goes all the way down here. So this is a deep Chiari 1 malformation. There is a small posterior fossa, so we're talking about the true blue Chiari. So the small posterior fossa is squeezing the brain out like you would squeeze a tube of toothpaste, and the tonsillar descent made it all the way to the second vertebra. Now, this is not what makes it a complex Chiari. It makes it a complex Chiari because the brainstem, which is the continuation of the spinal cord towards the brain, towards the inside of the skull, is getting punched by two places. It's getting punched and pushed from behind by the tonsils, and is getting punched from the front by this structure over here. This structure, which looks like a little birdie coming up, is the odontoid, which is part of the second vertebra. This odontoid is supposed to be in a certain angle with the base of the skull. It's supposed to be having a sort of a breathing room in reference to the upper part of the spinal cord and the brainstem. But in this case, as you can see, it's tilted backwards and is creating an indentation in the brainstem. So this is what the problem here is, not only just a Chiari 1 malformation, but a Chiari 1 malformation plus something else coming from the bony anatomy of the craniocervical junction. What is the relevance? And here I'm quoting heavily from the seminal article of Dr. Brockmeyer. Chiari 1 malformation is often associated to anterior pathology of the craniocervical junction, which is around 25%. It include a laundry list of conditions that you've heard in your going around websites, etc. Basilar impression, basilar invagination, retroflexion of the odontoid, craniocervical instability. These are all somehow overlapping concepts, but they have one thing in common. There is something wrong at the junction between the skull and the neck, and that's compounding the injury of the Chiari. There are also situations in which more complex congenital bone malformations and connective tissue disorders can also be involved to topple that, and that makes the situation even more complex. Whenever you have a situation like this one, the patients tend to have a more complicated and more complex, again, I keep using this name, clinical presentation. So these patients like this do not have just the Chiari headache and period, but they have a lot of other problems which come from the direct mass effect, which means the pushing and the punching and the knocking on top of the brainstem. So a lot of distress calls coming from the brainstem are also intermixed with the garden variety of Chiari symptoms that all the other patients with Chiari who do not have the complex Chiari do have. So how do you quantify this condition? Because everybody starting from this say, all right, looks pretty messed up to me, but how do you quantify? How do you distinguish you are pretty messed up or you are very messed up? So one of the good ways to start is to start doing measurements. Measurements for the craniocervical junction, which is all these bones at the border between skull and neck, have been around for a number of years since the X-rays were invented. Some of these measurements, that I'm going to show you now, are as old as I am, and I'm old as dirt. So the principle number one for the morphometrics, which is this discipline applied to measurements on the X-rays, is that for everything concerning the craniocervical junction, you need at least 2 measurements, because each and any one of these are going to see the same problem from a different perspective. So, for example, you see a flounder like this, and it looks like an enormous fish. You see him from the other direction, you see, I shouldn't be that scared after all. So you need 2 parameters at least. The parameters which are the most trendy and the most sexy right now are the so-called grab measurement and the CXA, or claviaxial angle. This is an example of the grab. The grab Oaks measurement, so aka PBC2, is the measurement of this semi-horizontal line, which is coming out at a perpendicular angle from this reference line here. I'm not going to go into specifics. This is just for you to have a taste about, yes, we have a way to measure this place and to quantify it so we can compare what we're doing is having an effect. And we can also compare one patient who has a mild malformation with another who has a patient who has a severe malformation. And we can also decide surgical thresholds. And I can say, okay, up to here, I'm not going to touch them. Above this, I'm going to do something serious. The grab measurements has a role, and it quantifies the mass effect exerted by the tip of the odontoid plus its ligamentous complex on the adjacent brainstem. I'm translating in English. The birdie from before, that's a piece of bone here, and this here is painted in light gray. Around here, you see there is an area which is more blackish. That's a ligament. The ligament are rubber bands keeping the bones together, keeping the joints together. In patients with certain kind of disorders, these ligaments become very thick. And so if you have a bone which is tilted backwards towards the brainstem, plus you also have a thick ligament, you have a double whammy pushing the brainstem. So you understand now that this semi-horizontal line is reflecting how much the sum of the bone and the ligament is invading the space, invading the breathing room, which is in the front of the brainstem. There are no definitive data about what is normal and is abnormal, but everybody agrees that in the field that less than 6 millimeters you're safe, 6 to 7.9 is borderline, and then above 8 is abnormal. Now, about what the surgical threshold changes from doctor to doctor, there are not so many people who are dealing with craniocervical junction at the surgical level. So there are some people who say 8, some people will say 9. Time will tell. This is a skull of a Chiari patient who has been operated on, so this part of the bone has been cut off. And you're seeing down the spine. So you're kind of traveling in the direction of the brainstem and the spinal cord. And this is the odontoid. The odontoid over here should not be there. This is invading this space, which is the space where the spinal cord and the brainstem are. So this odontoid should be up here where my line is moving. So all this is like a fist embedded in my stomach like this. And that does not make the brainstem happy. This is an ultrasound obtained during the surgery. This is a so-called Marie Antoinette cut. So imagine that I cut my head like this and then I show you from the top. So this is the bone, the so-called birdie. If you cut it like this, it becomes just a circle over here. And this area here is all the thick ligament that I was telling you about, the rubber bands keeping the joint together. And as you see, this being the cervico-medullary junction, which is the junction between the lower part of the brainstem and the upper part of the spinal cord, these two things are touching each other. And they're touching each other during the respiratory cycle. It means just the act of breathing brings the brainstem against this. Now, you should have at least some millimeters of breathing room between these two structures, so this patient has a basilar impression. The brainstem is not happy when you poke it, especially if you poke it repeatedly. This is the claviaxial angle, which is the angle between the base of the skull and a specific part of the birdie we are talking about, which is the odontoid. There is a specific angle with value normals, and the angle should be around 145 degrees, in excess of. So anything between 145, 155, 160 is the domain of normal. Then there is a borderline between 136 and 145, and anything below 135 is recognized to be pathological. Now, about when to intervene surgically, that's another pair of hands. Now, what does this angle, tell us? It tells us it is linked to a stress deformity of the brainstem, which gets stretched on the tip of the odontoid, which in turn acts like a fulcrum. Again, let's go back to the picture. to this one over here. Actually, I'm going to go back to this one, which is going to be even better. You see that over here, the brainstem wraps around this. So this is an area. Look at the microphone. Look what I'm going to do. Look at my finger. My finger is a fulcrum, which means it creates a point of distress on a deformable object. So let's go back to the definition. So if my odontoid is the fulcrum and the brainstem, which again is a very delicate part of the nervous system, is stretched around and getting pushed, it creates a stress deformity. In anatomical preparations, which means studies on cadavers, it has been seen that wherever there is a stress deformity, there are actually some microscopical damage, and sometimes more than microscopical damage within the nervous tissue, within the brainstem. Now, so we have a complex Chiari. You have the pathology of association of Chiari-1 malformation and a deformity or an anomaly of the craniocervical junction. Not everybody who has a complex Chiari needs surgery, number one. Number two, people with complex Chiari have more chances to become symptomatic because there is more compression, more things going on. So the chance to stay asymptomatic for your lifetime is less likely. Number three, whenever you need surgery, an indication for surgery we're not going to discuss now, but obviously like for Chiari, you need to be sick enough to justify the risk-benefit ratio of a surgery. That point, when you get there, you have two pathologies and you need to do two surgeries, sometimes even three. The surgeries in question are the posterior fossa decompression, which is the Chiari surgery, and the other one is some kind of surgery to fix the boo-boo which is going on at the craniocervical junction. And sometimes this is enough, and sometimes this is not enough, and you have to add another thing which is called odontoidectomy or transoral odontoidectomy. Let's go through it. This is the anatomy of a patient who had a Chiari surgery. So small Chiari decompression over here within the bone, the opening of the first vertebra, which is called simual laminectomy, and then you see the classic finger birdie coming up. This is the odontoid. This is all the way through. We're looking through the brain because in this picture, all the nervous tissue is being filtered off. So the Chiari surgery here is very visible. Now, if you have also an unstable joint, you have bones that are out of place or they're pushing the brains, and so removing the Chiari is just removing one of the buns of the sandwich. There is still the other one which is causing problems for the brainstem. So one of the ways to stabilize this joint, which goes from the skull to the second vertebra, is to create a Volvo headrest. The Volvo headrest means you put screws in the back of the skull, screws in the top of the cervical spine, and you bridge them with two bars, one on the right, one on the left. So go in here, you put screws over here, screws here, and then you put one bar on the right and one bar on the left. So now you have an idea in space about what's happening. This is the way it looks on an X-ray seen from the side. All this hardware is quite long. It can be up to 18 centimeters and long, which is about, you translate in inches, 2.5 centimeters per inch. And this is the way it looks on 3D CT. So kind of same patients later. This is the way it looks, like from the side and all the way to the front. And what we want is we want the hardware to be covered by bone, because the hardware by itself, after a while, like a paper clip you play with, is going to break or is going to bend. So you want bone to reinforce this. So you have these two pillars of armored cement with titanium reinforced by bone, which is taking care of the craniocervical anomaly. And you have your Chiari decompression here, because here you're missing the bone, you did whatever you have done inside the dura or outside the dura. So this is one of the ways to deal with it. Sometimes, and nowadays it's less and less, you also have to do a transoral odontoidectomy. I do probably 4 or 5 transorals per year, and I'm a quaternary, we're part of a quaternary Centers for Chiari. So It's a small minority of the people who have this complex Chiari. But you had to be equipped and you had to be prepared that if the first two are not enough, you have to go all the way. When do you do it? You do it whenever the fusion is unable, with all the maneuvers you do during, to decompress the brainstem effectively from that birdie embedding itself in the odontoid, in the brainstem. So you go through the mouth, because the odontoid is just in the back of your mouth. You can actually tickle it when you reach all the way with a finger. And you go through the mouth with this kind of saw-like, if anybody saw the movies Saw, you can be familiar with this. You go all the way to the top, to the mouth open, and you go with the drill, you drill down this bone, and the trick is to stop before you reach the brainstem, because if you go through the brainstem, the operation ends up in a lot of paperwork. Now, so far, it's a lot of problems, so everything looks pretty simple. Okay, you got two surgery, you got two pathologies. If you need to do the surgery, there are two surgeries, simple. Nothing is really simple. So there are a lot of questions once you start to tackle this problem. The first one is you do these surgeries at the same time, in the same day, and you're done. Or you do first one and do the other. So the first dilemma, you do them staged or combined. Then the other problem technically, and you guys haven't thought about it yet, but you kind of stumble on it once you start dealing with this process, is that the Chiari surgery and the fusion surgery are actually competing for the same piece of real estate, which is the piece of skull here in the back, which is called the supraocciput. These two surgeries deal with this piece of bone, which is the target, in two completely different ways. The posterior fossa decompression, which is the Chiari surgery, wants to remove bone. On the other hand, the fusion, to work long term, needs to add bone. So you have a dilemma. What do? You shortchange one or the other. The craniocervical fusion needs wide access to thick occipital areas, because you remember those screws you put in the back of the skull? It's not very polite to put the same screws in the brain after you remove the skull, because the brain does not, bear screws very well. So you need areas of residual skull where you can attach your damn fusion. On the other hand, you cannot even shortchange your Chiari surgery because you are under decompressing the Chiari to make the fusion happy. So everybody is kind of dealing with their own formula about this. The formula that came up, it's already 2 years ago. I thought about it long and hard, and I said, all right, the way I was doing so far doesn't really work, so what do I do? All right, so I'm going to remove the minimum amount of bone possible from the Chiari surgery. And the concept for Chiari surgery, as you're going to hear from the experts later, is that you have to be buying space. Chiari is a space problem. There is small skull, normal brain, is like having a 12 foot in a 10 shoe. So you have to make space. And you can buy space on the outside, or can buy space on the inside, or both. Buy space on the outside, you cut bone, you do uroplasty. Buy space on the inside, you can shrink the tonsils. In my case, I went minimalistic for the amount of bone removed, and I ended up cutting the tonsils, which means subpial tonsillar resection means I cut between half and 2/3 of the tonsils away. It's not easy, but it allows me to remove less bone. And so I buy a lot of space in the inside and less space on the outside. And that allows me to more play with the craniocervical fusion. But then for another set of problems I'm not going to analyze here, I modified the fusion according to a recent technique to a condylar screw. So this is the final result. This is the same patient before, and this is the same patient afterwards. This big chunk of tonsil is gone, and the odontoid is now straight, and there is an effective breathing room in front of the brainstem. And the brainstem doesn't have a narrow waist anymore. It's getting expanded from here to here. The new technique I was mentioning, instead of putting the screws in the back of the skull where you're competing with the Chiari, we put the screws in the base of the skull. And the base of the skull is at the border between the skull and the neck in a pillar of bone called the condyles, where instead of multiple little screws, like back of the skull is 10, you can put two very long screws over there. Technically, it's not very easy to do. It takes a learning curve. But at the end, you have 2 screws at the base of the skull, 2 screws in the first vertebra, 2 screws in the second vertebra. You add the bars, and instead of a system which is 18 to 20 centimeters long bars, you have a system down to a 3 centimeter and a half. So it is 1 inch and a half of worth of bar. So it's much shorter, it's not bent, it's not prone. The old system would go from here down to here. This is much shorter, is more comfortable, has a longer learning curve for the surgeon, but has the advantage that is less vulnerable to bending and breaking over time. Now, these are all ways to deal with the problem. Every surgeon is going to have their way to do it. The take-home message is this: complex Chiari is a terminology which is getting used more and more by the Chiari experts around the country, and is now also finding its way in the chat rooms among patients. So now you know what's the concept of Chiari, complex Chiari. Complex Chiari is, in its purest terms, the combination of a Chiari-1 malformation plus something wrong with the craniocervical junction. Patients with this disorder, they tend to be more sick, they tend to have more complex clinical problems, and more often than the counterpopulation of the simple Chiari end up deteriorating faster, because we're talking about a snail versus a worm, towards the need for surgery. And when surgery is needed, you need to do 2 surgeries rather than just 1. The last thing that I want to say is that I want to symbolically say bye-bye to my old affiliation, the Chiari Institute. I'm going to leave the Chiari Institute at the end of August. I'm going to leave behind my dear colleague, and I consider him a friend as well, Dr. Ricate. And with him at the helm, the Chiari Institute is going to keep prospering. And I'm going to go ahead and foolishly start my own Chiari Neurosurgical Center 3 miles down the road. So we're going to compete head to head. Thank you very much.